Hi everyone, welcome to our session today on asthma and COPD. They do overlap. Just to begin, at Northwest Melbourne, I would like to Primary Care Health Network, I would like to acknowledge that the traditional custodians of the land on which our work takes place, the Wurundjeri Wurrung people of the Burrung people and the Wathaurong people. We pay our respects to both elders past, present and emerging, and any Aboriginal and Torres Strait Islander people in the meeting with us today. Just a couple of housekeeping. All attendees are muted, so please keep your microphone on mute. You can ask questions via the chat box, and we'll also do some questions at the end and possibly in the middle. This session is being recorded. Please ensure you join the session using your name that you registered with so that we can mark your attendance. Certificates will not be issued if we cannot confirm your attendance. How to change your name in Zoom. You can do this by clicking on participants. On the app, click on your name. On the desktop, hover on your name and click the three dots. And on a Mac, hover over your name and click more. Click rename and then enter the name you registered with and click done, change or rename. Our speakers today, Adila Ludin. Adila has been working with Health Pathways Melbourne team for 1 year and has a background in public health. And our second speaker today is Narelle Williamson. Narelle is a registered nurse and respiratory educator with over 25 years experience in acute hospital settings, primary healthcare and a paediatric palliative care. Narelle has developed nurse-led respiratory clinics in primary care for the last 12 years, most recently in Melbourne's East. She also travels Australia-wide, educating GPs, practice nurses and pharmacists in respiratory health, and as part of the National Asthma Council's education program, recently resigning after 3 years as their senior clinical consultant.
Adila, we could see your screen and then we lost it.
Yeah.
I see it. I apologize. Let's try again. Can you see my screen now? And it's my video as well.
Yep, perfect.
Technology is not on my side. It's happening. Let's see.
We're still waiting for people to enter, so no stress. Are you unable to move the screen forward? Is that your...
No, let's try now. So hi, everyone. My name is Adila London. I'm part of the Health Pathways team, at Melbourne. I'm a part of Northwest Melbourne PHN. So Health Pathways provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines. And the pathways are designed to support general practitioners and other providers in delivering consistent and evidence-based care for their patients. Health Pathways Melbourne is a collaborative program run by the Eastern Melbourne PHN and the Northwestern Melbourne PHN, and is supported by local GPs, hospital, health networks, community health providers, and other health professionals. And this presentation will focus on Health Pathways Melbourne platform. However, please note that not all regions utilize this platform. So please do reach out to your primary health network for guidance on accessing their health pathway platforms. Just a little bit what Health Pathways do is that we So it's a platform that would allow GPs at a point of care to see, while they're seeing a patient, if there is if they're new to the area, or if there is a particular issue they're not really familiar with. They can jump onto Health Pathways. They can look at the local assessment criteria, management, and referral criteria. So when you jump onto Health Pathways for respiratory, you can click here, you can check COPD and all the different pathways we have. And when you're in the site, if there are any, let's say a link is outdated, or you have any recommendation to give to a pathway, you can jump on here and send feedback. So at this moment, we are currently reviewing several respiratory pathways, and we're including updates to align with the new statewide referral criteria for respiratory, which are being published and going live 1st of November. So we do encourage you to visit Health Pathways to access more information on asthma and COPD and a range of other respiratory pathways that I have not listed here because there are so many. And in addition, you may not be aware that Health Pathways is a tool that can help you with reflective learning that contributes to COPD hours. For both Australian College of Rural and Remote Medicine and the Royal Australian College for General Practitioners, you need to complete 30 minutes each of a performance review and educational activity. And after completing these, enter the details into the reflective activity template and submit them online with the links or via my CPD app, which is also available on Android or iOS. Here is a QR code to access Health Pathways. You can email us, and the link is there to access Health Pathways. And I will also put in the chat how you can access Health Pathways if you were interested. And please shoot any message if you have any. Thank you.
Thanks, Adila. Narelle, we still can't see your screen.
Okay, let's try now.
No,
Can you see that now?
It was in presentation mode before you just clicked, whatever you just clicked.
Let's have a look. Is that better now?
Perfect.
Great. Okay. Sliding through all right? Perfect. Hi, everybody. I'm Narelle. There might be some people out there that have met me before. I've done a few sessions for not just Northwest Melbourne PHN, but all the PHNs in Victoria and Tassie before. So welcome. I hope everyone's had a good day. Thank you for joining after what has probably been a long day for you all. This is our session, as you all know by now, on asthma and COPD. They do overlap. So we're going to summarise asthma and COPD as single entities, but tonight is really about the overlap of the two. So what we're going to do is we're going to learn how to access the COPDX and asthma management guidelines. We'll identify the differential clinical features between asthma and COPD. We're going to summarise the current guidelines for medication management, and then I'll summarise the importance of written asthma action plans, my pet topic. So this is the website for the Australian Asthma Handbook. So the handbook is evidence-based best practice guidelines translated into practical advice, if you like, for primary healthcare professionals. And at the NAC, we have a guidelines committee made up of GPs, practice nurses, pharmacists, and respiratory specialists as well. So we do a major update of the handbook every couple of years and some minor updates in between. So you can jump online and find this, this site. It's no longer in paper copy, just online, but you can download lots of bits and pieces. Just type anything into the search box and anything and everything to do with asthma and more is in there. And we're currently developing a quick reference guide. So this will be an accompaniment to our larger asthma handbook. It certainly doesn't replace the handbook, but it's a small, quick version. And then we'll be soon following with the pediatric quick reference guide as well. Any of the charts or resources that you see me present tonight, they can all be found on the National Asthma Council website, as you can see on your screen. You can order any of those resources online. We can send them out to you, or you can call the office and the lovely Yvonne will send them out to you. But you'll find our medication charts, our first aid for asthma charts, information papers, our how-to video library, which I'll talk a little bit about later. And that's a really easy site to navigate as well. This is the Lung Foundation Australia website. So we work very closely with the Lung Foundation Australia. They're actually in the same building as the NAC, but similarly, you can find many resources and information on lots of lung diseases, COPD, lung cancer, childhood interstitial lung disease, and many more. They have health professional online courses. And this website also will house any of the charts or resources that you see tonight when I talk about COPD. The COPDX guidelines, also known as the COPDX plan, are the Australian New Zealand guidelines for the diagnosis and management of chronic obstructive pulmonary disease. The latest version is December last year. So similarly to the asthma handbook, these guidelines aim to provide evidence-based, practical recommendations for primary healthcare professionals. So much like our handbook, this is a COPD Bible, and they have a concise guide, which is the picture that you can see there on the screen as well, which, as the name suggests, is a nice, concise summary of major points in the COPDX guidelines. All right, so that's enough about resources for the minute. Let's look at some stats regarding asthma to begin with. And this data comes from the Bureau of Statistics in 2023. So it's 2022 stats. So just under 2.8 million or 10.8 Australians had asthma in 2022. And this equates to 11% or 1 in 9 Australians, which is high by international standards. And over the last decade, the prevalence of asthma has remained steady from around 10.2% in 2011 to 10.8% in 22. Overall, females are more likely than males to have asthma. However, among children aged 0 to 14, boys are more likely to have asthma than girls. That's about a 10 compared to a 6% difference. And that pattern has actually been consistent since 2000-2001. 467 asthma-related deaths were recorded in Australia in 2022, unfortunately, and that was made up of 299 females and 168 males, up from 355 deaths in 2021. So that's a 30% increase in asthma deaths in 1 year. That some of that, of course, has to do with the fact that we came out of lockdown and people were getting respiratory infections, which is often a trigger for asthma. But almost 1 in 3 people only have a written asthma action plan. 2 in 3 children, or around 68%, had a written action plan in 2022, but only 1 in 4 adults had a written asthma action plan. And I think the higher ownership of action plans in children is definitely because schools, kindergartens, childcare centres, if a child has asthma, they have to have a copy of a written asthma action plan, but still the ownership is extremely, extremely low. 1 in 3 people of all ages used medication daily, and 4 in 10 did not even take medication. So around 50% of people with asthma over 75 actually haven't been diagnosed by a doctor. So diagnosis is a big thing. We find a lot of people are told by their neighbours or the relatives, oh, you've got asthma. Short-acting beta agonists or bronchodilators or relievers, all the same thing, such as Ventolin. They're available over the counter. They're inexpensive. A lot of people don't have a proper GP review needless to say, or a formal diagnosis, including spirometry testing. So we need to really, through education sessions like this, we need to educate our primary healthcare professionals, get the diagnosis right, and then obviously the treatment and management right. With regards to COPD, and these are stats from the Lung Foundation back in 2023, last year, 7.5% of Australians aged 40 or over have symptomatic COPD, and of those, 3 in 4 people aren't aware that they have it. So they mistake their symptoms for asthma or for old age or just lack of fitness, and they're definitely unaware of the slow progressive nature of the disease that COPD is. The overall prevalence doesn't differ between males and females, but for ages 55 to 64, the rates are significantly higher in females. 20 to 30% of patients given a clinical diagnosis of COPD do not meet the diagnostic criteria. So again, diagnosis is really, really crucial. And in 2021, COPD was the leading underlying cause of death in Australia with 7,020 deaths, which is 4.1% of all deaths. So it's definitely an increasing problem. But again, with education, hopefully we can combat some of it. So remember, asthma is a chronic lung disease. It can be controlled, but it can't as yet be cured. Asthma is defined in clinical practice by the presence of both of the following: excessive variation in lung function, and we measure that objectively with spirometry or lung function testing, and variable respiratory symptoms, which of course are reported to us by the patient. And associated features of other allergic conditions such as rhinitis and eczema may be present. There might be a family history. Someone might have had childhood asthma. Symptoms may rapidly be relieved by a bronchodilator such as Ventolin. There may be eosinophilia or raised blood IgE, which can all help us lead to correct diagnosis. COPD is a common, preventable and treatable disease. It's characterized by persistent respiratory symptoms and airflow limitation, and that is due to airway and or alveolar abnormalities. The chronic airflow limitation is caused by a mixture of small airways disease and parenchymal destruction. So, for example, obstructive bronchitis and emphysema. COPD is not fully reversible. Airflow limitation is usually progressive, and again, it doesn't have a cure at the moment, maybe one day. And the irreversible component of airflow limitation is the end result of that inflammation, fibrosis, and the remodeling of peripheral airways. Diagnosis of COPD can be mild, moderate, or severe based on spirometry results. And in clinical practice, diagnosis is usually based on symptoms of exertional breathlessness, cough, sputum, a history of smoking or exposure to other noxious agents, the ratio of FEV1 over FVC of less than 0.7 post Ventolin on spirometry, and further investigations are often required, for example, AAT deficiency, which is a rare genetic condition that predisposes us to lung disease. It may initially be present with adult onset respiratory symptoms and airflow limitation. There's no cure, but we're testing a lot more people these days for alpha antitrypsin deficiency. When we think about our patient-centered care, asthma versus COPD, we need to remember for both diseases and certainly for asthma COPD overlap that ongoing education is important for disease outcomes. We often find that our asthma patients present to hospital or to our clinics acutely ill. They will accept immediate treatment. They'll feel relief of symptoms usually once they've been given bronchodilators. They may be reluctant for ongoing management and therefore need support and education to maintain ongoing treatment. And that is in relation to preventers. Because they feel relief from reliever medications or bronchodilators, they often don't continue to take their preventers because preventive medications don't give immediate, within minutes sort of relief. But they need to understand that the basis of asthma is inflammation inside the lungs, and only preventers can help that inflammation. Patients also may not understand the disease process for future risks, and the treatment aim for asthmatic patients is to restore lung function and, of course, reduce future risks. COPD patients, well, they present to us, or they're diagnosed at different stages of the disease process, and 10% are at risk of dying post an exacerbation that requires hospitalisation. Some patients are reluctant to accept the diagnosis, or they can be quite frightened once they understand the progressive disease process. They may feel a sense of guilt if smoking has caused the disease, and the treatment aim is to optimise lung function, manage exacerbations, and develop support networks and self-management. So approximately 20% of patients with obstructive lung disease have features of both asthma and COPD. And it's not, asthma-COPD overlap is not a single well-defined disease, but it's likely to have many underlying causes. So a specific definition has not actually been developed yet until more evidence is available about its clinical phenotypes and underlying mechanisms. But overlap can develop in smokers, ex-smokers, or non-smokers. And asthma COPD overlap is now recognised as a really important clinical problem, and primary care was pivotal in identifying those patients with overlap. So people like us as respiratory educators or nurses, GPs, pharmacists, we can identify a lot of patients who may have asthma COPD overlap. We provide initial therapy and refer to specialist care as appropriate. People with asthma COPD overlap often have poorer disease outcomes compared with people who have COPD or asthma alone, and they have found to have increased burden of disease, and that includes more symptoms, lower quality of life, more hospitalisations, more comorbidities, increased mortality, higher healthcare costs, and more exacerbations. So, as I said, there is currently no specific definition for asthma COPD overlap, but distinguishing between typical asthma and typical COPD is straightforward. However, it can be difficult to distinguish COPD from asthma in adults who have features of both conditions. So our description for clinical use is that asthma COPD overlap is characterised by persistent airflow limitation, with several features usually associated with asthma and several features associated with COPD, and that's the clearest we've come up with so far. So a previous diagnosis of asthma or COPD, a chronic or recurrent cough, sputum production, dyspnea, wheezing, recurrent acute lower respiratory tract infections, exposure to tobacco smoke or other airborne pollutants are all possibilities of symptoms. So the diagnosis of asthma COPD overlap is based on symptoms and an assessment of lung function and airway inflammation. So we want to collect a detailed medical history. Has there been or is there chronic or recurrent cough, sputum production, dyspnea, wheezing, all of those things that I just mentioned before? Then we conduct a physical examination, and this may be normal, or there may be evidence of hyperinflation or abnormal auscultation. Then we always need to perform lung function testing. The most common is spirometry. The diagnosis of obstructive lung disease definitely relies on spirometry, and pre and post bronchodilator testing must be performed. In other words, breaths performed before Ventolin puffs and breaths performed after Ventolin puffs. I think it's only some medicals we do, you just have to perform the pre-Ventolin blows, but in order to diagnose asthma, COPD or overlap, pre and post needs to be performed because we need to see if there's that airway reversibility. With radiology, it's not routine for asthma, but a chest X-ray or CT scans, potentially an MRI, may identify an alternative diagnosis. So people with overlap may have airway eosinophilia, neutrophilia, or a mixed pattern of airway inflammation. And we should suspect coexistence of asthma and COPD in middle-aged or older patients with a history of cigarette smoke and a diagnosis of asthma before the age of 40. This slide indicates the benefit of spirometry in the diagnosis of asthma-COPD overlap. Early spirometry will detect the changes in lung function at around 40 years of age, whilst the other indicators of COPD, such as symptoms, chest X-ray, blood gases, remain within the normal ranges. And it's not until the age of 50 or above that these tests start to show change. So spirometry, again, I've hopefully shown that early testing can really be beneficial. We find that a lot of patients tolerate their symptoms such as cough and sputum until they become breathless. They don't want to attribute this to any condition, and by then the COPD can have, and a lot of the time has, progressed to significant loss of lung function. So as I've said, and as I'm sure you all know anyway, the diagnosis of obstructive lung disease relies on spirometry pre and post bronchodilator. And this slide shows examples of spirometry tracings in a normal, healthy airway, in an asthmatic airway, in someone with COPD and COPD overlap. And the black dashed line that you can see indicates spirometry pre-bronchodilator or pre-Ventolin, and the red line is post-bronchodilator. So airway reversibility, the definition is an increase in FEV1 of over 12% and more than 200 mils following bronchodilator use. So FEV1 is the amount of air expired in the first second of a breath during spirometry. So it's normally 12% and 200 mils. And so while some reversibility of airflow limitation with bronchodilators may be found in patients with COPD alone, an FEV1 increase of more than 400 mils suggests coexisting asthma. So you can see the bottom right-hand graph indicates a difference between pre and post bronchodilator FEV1 more than 400 mils. So it just goes to sort of illustrate that in asthma COPD overlap, you do see a big change in those pre and post bronchodilator results, more so than in a purely asthmatic airway or in a COPD affected airway. This is a good little table adapted by the Global Initiative for Asthma and the Global Initiative for COPD. And it just shows the differences in the features of asthma and COPD. So we'll run through them quickly. With asthma, the age of onset is usually before 20 years of age. With COPD, it is after the age of 40. With the pattern of symptoms with asthma, symptoms vary over minutes, hours, or days. Symptoms are often worse during the night or early morning, and symptoms are triggered by exercise, laughter, dust, and other exposure to allergens. With COPD, it's a persistent disease despite treatment. Shortness of breath is usually activity-related and can resolve with rest. And there's usually a chronic cough and sputum and unrelated to triggers. With lung function, with asthma, it's a variable airflow limitation, but with COPD, it's persistent. Lung function between symptoms of asthma can return back to normal, but however, with COPD, it's abnormal lung function in between exacerbations. So they always have abnormal lung function. With regards to past history and family history, with asthma, there's usually a previous diagnosis of asthma, family history of asthma, or other atopic or allergic conditions. And the smoking history is usually 0 or less than 15 pack year. And with COPD, there's usually a previous diagnosis of COPD, heavy exposure to risk factor tobacco smoke or other noxious agents, as I said earlier. With the time course with asthma, there's no worsening of symptoms over time, but it can be seasonal. And there's usually a rapid response to bronchodilator or inhaled corticosteroid over weeks, whereas with COPD, symptoms slowly worsen over time and rapid-acting bronchodilator provides only limited relief. Just for those of you, when I said pack years, you can see the definition down there. So if any of you are performing spirometry, a lot of the software wants you to put in pack year history. You determine that by doing an equation. So it's the number of cigarettes the patient smoked per day or did smoke per day times the number of years smoked. And then you divide that by 20 to get your pack year history. So it's a good little table just summarising the differences between asthma and COPD. So looking at management of asthma and COPD overlap, we have bronchodilators for symptom control that we often prescribing. If there's any features of asthma, we would prescribe a regular, low or moderate dose of inhaled corticosteroid. And depending on symptoms, we might consider adding to an inhaled corticosteroid a long-acting beta-2 agonist, or a LABA, or a long-acting muscarinic antagonist, also known as LAMAs, or a LABA-LAMA combination. And don't worry, I'll explain them as easily as I can, or in easy terms, I should say. With regards to management, all patients should have an action plan, updated regularly. We need to monitor and treat any respiratory tract infections, and self-management support and education is key. So we need to manage asthma COPD overlap as a chronic disease. That's because it is. But our patients need ongoing care. It's not a matter of just seeing them once. We need to review them regularly throughout the year, normally 3 or 4 times a year, minimum 2. We need to address smoking cessation. We need to encourage them to eliminate passive exposure if that's a relevant trigger, because smoking cessation is the most important intervention to prevent worsening of COPD. We need to identify any triggers, including avoidance strategies for those triggers, and we need to discuss vaccinations, particularly against influenza and pneumonia. Vaccination should be actively promoted in our asthma COPD patients. And in the updated edition of the Asthma Handbook late in 2022, COVID vaccination and pertussis vaccinations are also suggested now. Although we're used to pertussis infection generally being associated more with children, it's generally not as severe in adults. It can definitely be associated with worse symptoms and severe disease in people with asthma and COPD. Then we need to refer on and discuss pulmonary rehab with our patients. Pulmonary rehab includes self-management education, healthy, well-balanced diet, exercise regimes, and stress management. Tobacco smoking, I'm pretty sure everything on here everybody knows, but it's the largest single preventable cause of death and disease. Passive smoking leads to increased risk of everything that's listed there. Smoking in pregnancy increases health risks to mum and bub. Smoking worsens asthma and COPD, etc., etc. And this cool slide or graph demonstrates how smoking affects lung function, but perhaps more importantly, it shows us how smoking cessation reduces the rate of decline in lung function. So in all of us, our lung function falls gradually over a lifetime, and that is shown by the solid blue curve at the top of the graph. A person who smokes regularly from the age of 25 is susceptible to the irreversible obstructive changes to the airways, and lung function declines steadily, as shown by that green line. Now, the onset of symptoms often doesn't appear until there's a significant decline in lung function, but if the person stops smoking, he'll not recover his lung function as such. However, the average loss of function will revert back to the normal deterioration as shown by the blue dashed lines. So, for example, if a person starts smoking regularly at 25, of course, their airways are susceptible to the effects. Their lung function will decline steeply according to the green line. If they quit at 45, they may have not yet experienced the onset of symptoms, and their lung function reverts back to that normal rate of lung function we experience in our lifetime. If that person continues to smoke until they are 65, they will then be suffering severe disability and a fast-moving progression of decline in lung function. If they were to quit at 65, however, their decline in lung function will slow down. They will hopefully experience fewer exacerbations and may increase their life expectancy. But we hope by showing this slide to our patients that any time to show them that any time to stop smoking is a good time, as lung function can revert back to the normal decline. When I speak to patients about quitting, it can be a tricky conversation, and you certainly can tell by your patients and your history with the patients whether you can push a little bit harder or not. But I generally like to say a couple of points to them. Smokers who quit at age 50 halve their risk of death caused by smoking, and quitting by age 30 avoids almost all of the excess risk associated with smoking. And a favourite saying at the NAC is that it's far better to try and try again than to fail to try again. Okay, I'm just going to have a sip of my tea, ask if there's any questions, but we will have time at the end for some questions as well. So please feel free to type anything into the chat box, or I'm not quite sure, Alyssa, if they can unmute themselves or not.
There's 2 questions in the chat box, Narelle, and now another one just come through. Do you want me to read them out to you?
Yeah, that'd be good. Thank you.
Okay, so do we know whether vaping causes or cannot talk tonight, exacerbates COPD?
There hasn't really been a lot of literature released thus far, but yes, we know that vaping is as bad, if not worse, than smoking. So we are assuming that it can cause COPD, similar to the smoking, but I don't usually comment too much on that. I get asked that every time I present, but we assume so, but there's not been enough trials or evidence yet.
Our next question, should patients have annual spirometry RV as well as originally?
Yes, they should. So everyone, a diagnostic spirometry, which is a different item number, that will be performed, and then every 6 months at least, you would be needing to review spirometry. Obviously, if a patient has an exacerbation, particularly if they've ended up in emergency department or admitted to hospital, we would review them and then perform a spirometry about 4 to 6 weeks after that exacerbation. So yes, you need to be performing a review spirometry at least 6 monthly, but possibly more.
And then the next question was, I want to clarify the definition of asthma and COPD according to spirometry. Are you able to provide the criteria for COPD and asthma diagnosis as per spirometry? And then there was an example as well, which I can share with you.
I might end up, that could take we do an actual spirometry course, full day course, and we discuss the interpretation of spirometry for asthma and COPD, and it takes about 2 hours. So what I might do, Alyssa, is send you through some of our resources, and you can email them out to our participants tonight. That's probably the quickest way to to give details on that, because there's quite a lot involved with ratios and statistics and things like that, if that's okay.
Yeah, perfect. I'll send that through later.
Yeah, beautiful.
Is a 6-monthly RV's residual volume bulk build? Review, sorry. Thank you.
It depends on each clinic. As we know, a lot of our clinics are privately billed now, so that depends on individual GPs and individual clinics. But yeah, I think the MBS item number, I think you get $22 only for a review spirometry, and I think it's 44, might be up to 46 now for a diagnostic spirometry. So it's not overly worthwhile to a clinic. So again, each individual GP's discretion.
And just final one, why is the PAC year history now significant? Is this new?
No, it's not new. It's been used for, many, many years. Some software wants you to put it in. Some software, when performing spirometry, will just want you to identify whether a patient is a smoker, and a non-smoker, or an ex-smoker. But most software, when you say that they're a smoker or an ex-smoker, will want that pack year history. So maybe if it doesn't, it might be time to speak to your clinic practice manager and get some new software, because it definitely plays a part.
I think that's it for the moment.
Thank you. We'll move on. All right, so now we're going to discuss, as briefly as I can, the asthma and COPD medications. This is our current medication chart, continually updated and continually getting busier and busier. I think when I started in respiratory education, we had maybe 10 medications on the chart. So just keep an eye out, because as new medications come onto the market or go off the market, the chart may not always be up to date. But it is preferable, I might say, with our patients to minimise the numbers of different types of inhaler devices to avoid confusion about inhaler technique. For example, I saw a patient and she came in with a Ventolin metered dose inhaler. She also had a Flixotide Accuhaler, and then a respiratory specialist wanted to put her on Trilogy Ellipta. So where possible, always try and use the same type of device. It's so much less confusing for patients. And studies have reported recently that as few as 8 to 10% of Australians use correct technique with their medication device. So the NAC, we developed a how-to video library, and regardless of the type of inhaler device prescribed, patients need individualized, repeated hands-on training in correct inhaler use. So every time you see someone for a review of their asthma, always get them to bring in their devices, similarly with COPD. But we decided to develop this how-to video library so that patients and health professionals alike can look into this library as many times as they like. There's demonstrations of correct technique with all the main types of inhalers, but also includes demonstrations of nasal sprays as well. And there's a QR code that links directly to our how-to video library on the bottom of I'll just show you, on the bottom left-hand corner there, the how-to video QR scanning code there, and we have it on our allergic rhinitis treatment chart as well. Okay, briefly with our medications for asthma and COPD and overlap, we have our reliever medications to begin with. These are also known as short-acting beta-2 agonists, or SABAs, also known as bronchodilators, and they're used for short-term relief in asthma, COPD, and overlap. As I said, they have a direct bronchodilator effect on the muscles around our airways, and they can last for up to 4 hours. Recent guidelines recommend against treating with SABAs alone, and they should definitely not be used in the absence of symptoms. The most common ones you would know are Ventolin, Bricanol, and Atrovent. Then we have our long-acting beta-2 agonists. As the name suggests, they produce prolonged bronchodilation, so up to 12 hours with these guys, as opposed to 4 hours with the short-acting beta agonists. So the long-acting beta agonists shouldn't be used in people with asthma or asthma COPD overlap unless they are also taking an inhaled corticosteroid in combination or separately. However, for patients with COPD alone, the guidelines recommend a long-acting beta-2 agonist as initial treatment and an ICS added in, only for patients with more severe disease. Our examples are Oxys, Serevent, and Onbreeze. And I might just say here that the current asthma guidelines and COPD guidelines, they make contrasting recommendations for pharmacotherapy based on differing safety findings in each population. So special considerations are needed when a patient has features of both disease. Then we have our LAMAs, our long-acting muscarinic antagonists. These are formerly known as anticholinergics back in the day. So again, these are long-acting bronchodilators. Similarly to our LABAs, our LAMAs should not be used in people with asthma or overlap alone unless they're also taking an ICS. And the common ones you may have heard of are Spiriva or Respimat, Brolta-Sonda's a new one. They're all once daily maintenance doses. Incruisilipta and Britaris Genuair. Then we have combination therapies. One of our combination therapies is a single device consisting of a LABA and a LAMA. So a long-acting muscarinic antagonist and beta-2 agonist in combination, and that is better than either as a monotherapy. They're only prescribed for COPD. You may have heard of Brimicare, Genuair, Spiolto, Anora, Ellipta, and Ultibro, Rees-Haler. We also have a combination therapy, a single device consisting of an inhaled corticosteroid and a long-acting beta-2 agonist, or a LABA, so ICS-LABA combination therapy. These are probably the more popular, and you will no doubt have heard of Seretide, Fludiform, Symbicort, Duores Spiramax, Foster, Brio-Ellipta. We have to be careful with these ones when educating our patients. Tell them that they can possibly expect side effects due to the inhaled corticosteroid, and that can be a hoarse voice or some oral thrush. With all of these medications, it's always important to check PBS criteria. Seretide, for example, is registered for use in children 4 years and older, but Symbicort is not registered for use until 12 years of age. Guidelines are always changing, so it's always important to check PBS listings for maintenance doses. PBAC meet quarterly. There's been a couple of reviews with regards to a few of our combination therapies in the last 2 years, but they haven't been accepted. But yeah, there's just always changes coming. Then just to throw into the mix, a triple combination. So as the name suggests, ICS and a LAMA and a LABA. So studies have shown that triple therapy results in a lower rate of moderate or severe COPD exacerbations, and therefore better lung function and quality of life than the dual therapies. And triple therapy is usually most useful for patients with repeated exacerbations. So Trilogy Ellipta, as you can see there on the screen, it's indicated for moderate to severe COPD, a couple of the doses, and then another couple of the doses there are for once daily maintenance of those with severe asthma. There's different criteria for each, so again, you need to check your PBS. We also have Trimbo and Breztri, Aerosphere. They're both quite new medications. I also haven't popped onto the screen Enerzair, Rees-Haler, but Trimbo was reviewed with PBAC in March 22, and it was not approved, and I believe this year it was not approved either. Breztri is PBS listed for moderate to severe COPD, so that's a bonus, but always keep an eye, as I say, on the PBS listings and any changes and reviews from PBAC. With regards to written asthma action plans, well, I guess we need to remember that asthma is frightening for any child, any adolescent or adult who has an exacerbation, and for their parent or carer or families. And severe or life-threatening asthma or COPD exacerbations are more likely to occur in patients with inadequate medical supervision. And in the absence of medical supervision, which clearly is not always possible, written action plans clearly explain the steps to take to manage a person's asthma day to day and what to do during an exacerbation or an asthma emergency. Written asthma action plans must be individualised. You'd be surprised at how many people just get printed out an action plan. It hasn't been individualised terribly much. Their own medications might be on there, but we need to really make sure that they're an integral part of a patient's care and that they are individualised. They come in many different forms, but they should be developed so that a child, adolescent or adult with asthma can know what to do in an exacerbation, and and it is expected that all people with asthma and COPD, both overlap and in single entity diseases, have a written asthma action plan, and it needs to be current. Our plans should include their usual asthma medications, including treatment for related conditions. So that might mean someone has asthma and their trigger is pollen in springtime. So you might want to add into their action plan that they have Rhinocort from August to December when pollen season is at its peak. Plans should also include clear instructions on when to take extra doses or extra medications, when to contact a doctor or go to the emergency department. They all should have the name of the GP or the other health professional preparing the plan and the date the plan was issued. Advice about epidemic thunderstorm asthma, where to access pollen counts and forecasts, particularly in Victoria, because we are prone to thunderstorm asthma. It is also a nice piece of information to have on the action plans. So improved health outcomes have been shown to occur with the ownership of written asthma action plans. People tend to miss school or work less often. They wake less at night. They have improved symptom scores. And by owning a written asthma action plan, this significantly reduces emergency department and hospital presentations. These are the asthma action plan on the left-hand side from the National Asthma Council and the COPD action plan from the Lung Foundation Australia. So when deciding on an action plan for our patients who have been diagnosed with asthma COPD overlap, you would choose the plan depending on their dominant clinical features. So there's the NAC plan there. They're also available from Asthma Australia as well. They're available in a range of community languages and formats, as I said earlier. And the plans can also be generated using GP medical software or provided by hospitals. They often have their own templates as well. For children with asthma, their individualised written asthma action plan should be reviewed by a doctor or respiratory specialist every 6 months. And for adults and adolescents, every 12 months. In addition, they should be reviewed whenever their asthma control status changes significantly and or their medications are changed or ceased. And the COPD action plan should be reviewed every 12 months or again when medications are changed or ceased. This is the stepwise management of stable COPD available on the Lung Foundation Australia website, and it's a brief clinical tool. It's only 2 pages, and it shows a stepped care approach to evidence-based recommendations for managing COPD depending on the severity. So it's a part of the guidelines and the concise guide, and as I said, you can find it on the Lung Foundation website. But it highlights both pharmacological and non-pharmacological interventions and includes an image catalogue of PBS listed inhaler devices as well. So that's a really useful tool. So our key points as we're getting towards the end of tonight's webinar is that many adults have features of both asthma and COPD. Asthma, COPD and overlap are all heterogeneous disorders. Patients with asthma COPD overlap are at higher risk for more serious disease, more symptoms, more flare-ups, greater need for healthcare utilisation, and unfortunately greater mortality. Refer your patients onto a specialist for atypical symptoms, or if flare-ups still occur despite treatment, or if they have complex comorbidities, and it's so important to manage our patients holistically. I just wanted to quickly touch on our spirometry guidelines during these years and months where we've had COVID-19. I know things calmed down, but they seem to be ramping up a little bit. And so the NAC wrote infection control recommendations for spirometry in conjunction with the Thoracic Society of Australia and New Zealand. And the last update, it hasn't needed to be updated since August 2022, but you can find them at that link there. If you have recommenced spirometry in your clinics, you're more than entitled to now, but there just needs to be a few steps put in place. Don't perform spirometry clearly in COVID-19 positive patients or suspected COVID-19 positive patients. Always check that your patient is afebrile before you start to perform spirometry. Always use inline filters. They are to be used with all spirometry devices. The operator, so the nurse in most cases, always should have an N95 or P2 respirator, and it always should have been fit tested. Don't just grab a surgical mask when you're performing spirometry. And in the room where the spirometry is being performed, you need to ensure, if you can, 12 air exchanges per hour. Now that involves having a HEPA filtration system in the room where you're performing spirometry. If not, you need to check with your practice manager, who is usually the one that's in contact with the electrician or the air conditioning person in the building, and they need to be able to document and let you know how many air exchanges occur per hour according to the air conditioning system in your building. But usually most HEPA filters will bring those air exchanges up to 12 and you'll be right to go. But as I say, for a more in-depth summary or more in-depth guidelines, I should say, jump onto the Asthma Handbook under Clinical Issues tab, and you'll find it under COVID-19. There's just our couple of websites for our resources that I've spoken about and you've probably seen way too many times already. But tonight I can again send these out to Alyssa. And these are just our other webinar topics. We are doing another one at the end of August, the Asthma in Spring, Allergies and Thunderstorms. I'll be presenting that one as well. Very worthwhile webinar. So please register to attend if you want to know more, but particularly in Victoria here, where we are very prone to thunderstorm asthma, definitely worth a listen. Any more questions, Alyssa?
There's one in the chat in the Q&A. I had a patient on ICS, LABA, and I'm going to pronounce it wrong, inhaler. I suggested triple therapy, but GP responded that the patient had not had any exacerbations. If the patient is in effect taking triple therapy already, would the PBS fund triple therapy even without exacerbations? I hope I can re-say that if you need.
No, that's okay. It just depends. Sorry, did the question say they've got COPD or asthma?
No. Lauren, if you're able to speak, or just send me a message and I can add to that.
Because Trilogy, if it's COPD, Trilogy would be indicated for moderate to severe COPD. So if a patient's already on an ICS and a LABA and a LAMA, you would, in two different devices, they would definitely be fine to go on to a Trilogy. Trilogy is not indicated for the initiation of therapy in COPD. So it just depends on how many repeated exacerbations they have. For severe asthma, it's PBS listed, and that was back in April 2022. So the 200/62.5 and 25, patients must have experienced at least, I think it's one severe exacerbation in the 12 months prior to having first commenced treatment for severe asthma. So that means that they need to have trialed an ICS and a LABA or an ICS LAMA before they will get it on the PBS. So again, I can send out more information, but yeah, as far as I'm aware, it's not listed yet for COPD, but is for asthma in the moderate to severe categories. I hope that answers the question.
Yep, and then someone just added that both listed in history, if I remember correctly.
What was that, Alyssa?
They just said that, someone else has said that both listed in the history, if I remember correctly.
All right, okay.
Any other questions? Great, no other questions.
I'll stop sharing so you can show your last slide there. There you go.
Thank you all for joining today. I'm just going to share this QR code for you so you'll be able to provide any feedback on the session tonight. You'll also receive a post-session email within a week, which will include the slides, resources that was discussed today. An attendance certificate will be received within 4 to 6 weeks, and RSCGP CPD hours will be uploaded within the next 30 days. If you'd like to attend any further education sessions, please visit our website. And this session was also recorded, and you'll be able to view the recording at this link within the next week at North West Melbourne PHN website. Thank you so much for joining today, and I hope you all have a nice night.